Well, they're all esophageal Doppler
Yes.
Related variables, and it would be too long a title. Anyway, I'm actually from Worthing, which is on the seaside next to Brighton, which is far nicer than London. And this is a picture of our hospital, and as you can see, it's pretty shaky. Okay, conflict of interest statement. I've got to get all this off my chest. I have received some honoraria for lecturing and travel expenses, and my wife, as you can see, has an enormous shareholding, which we bought a few years ago with the idea that it would be nice to watch them go up and down, and of course they have in fact gone up and down. So anyway, there we are. I've come clean. Right, so the aims of the talk today are to explain what esophageal Doppler is, for those of you who haven't come across it before, explain how it works, how reliable it is compared with pulmonary artery catheter, etc., what the variables mean from the title, and a little bit of an idea of how it impacts on the patients. Right, so what is it? Well, it's essentially an ultrasound machine in which a continuous wave ultrasound is passed through an esophageal probe, which can be inserted through the mouth or through the nose, as here. I tend to use the probe through the nose because it tends to be more stable. And it essentially is a speed camera for the red blood cells in the aorta. It measures the velocity. Okay, so the way it does this, as I said, it's a continuous ultrasound, and the tip of the probe has got a receiving crystal and a transmitting crystal. And it works because the red cells have got a higher density than the surrounding plasma, so you get what's called an acoustic impedance mirror, which reflects the sound waves. And these reflections, as I said, come from the descending, the blood in the descending aorta. So this is essentially what happens. This little pointer's not that fantastic actually, but you've got blood flowing down the descending aorta, and the ultrasound waves are passed at 45 degrees, and using the Doppler equation, you end up working out the velocity of those red cells. And in the aorta, we have what's called plug flow. So the blood moves in a plug down the aorta. And so there's very little effect from friction at the edges. Now, as you get further down the arterial tree, there's a far more friction. And of course, you then end up with a laminar flow as you get the friction between the different layers of flow. But in the aorta, it's predominantly a plug that comes down. So your screen on the CardioQ, which we'll come to in a second, essentially gives you a triangle like this, with each systolic cycle. So here we are, the heart's starting to beat, out comes the blood, and the cells in the aorta, they accelerate, they reach a peak velocity, so we're getting back on track, and then they slow down again. And then you have the diastolic period, and then the next heartbeat. Okay, so that's the peak velocity there. The flow time, which is another part of the title, is the distance between these two lines here, which is the period in which the blood is flowing forwards down the aorta. So it's that systolic period where that plug's moved down the aorta. And those of you who remember from mathematics at school that the area under a velocity time curve is the distance travelled, and that's called the stroke distance. So there we are. That's how it works. And this is more like the screen that you see. You see a green signal follower once you've got it focused, and each of these little dots on this power density plot represents a red cell reflection. And what the machine does is it averages up the maximum velocities of all these cells, and then uses that to calculate the stroke distance by the area under the triangle. All right? The peak velocity, as I said, is the peak velocity. It's the fastest the red cells reach. And the gradient of this upstroke here is called the mean acceleration. And along with peak velocity, it gives you an idea of the contractility of the heart. So the stroke distance, as I said to you just a second ago, the maximum velocity values are taken, and the area under that systolic velocity time curve is measured. It's done beat to beat, so every beat is measured, and the device can be told to either display every single beat separately or to average over a number of cycles. Usually a patient in sinus rhythm would use 5 cycles, but a patient in atrial fibrillation, you'd average it over a longer period to get a more accurate overall picture. So it's essentially the distance that the column moves during systole. So there it is. That's what it is. And it is, of course, affected by the other variables. So it's affected by flow time, because if you can imagine that you've got a longer flow time, you have a wider base triangle, so bigger area. And you can imagine that if you've got a peak velocity that's higher, it's taller, it'll have a larger area, yeah, and smaller similarly. So all of these 3 variables are in fact interrelated. Now stroke distance is then converted to stroke volume by the use of a calibration constant. And the calibration constant was developed by matching stroke distances with stroke volumes assessed by pulmonary artery catheters. And so in various patients of various different age, weights, heights, races, everything was done to enable a large calibration to be done. So that's how the calibration actually works, to give you the stroke volume from the stroke distance. And here we are. This is the previous incarnation of the cardio-Q, and this is a very typical display. So here we have a normal beat, here we have a mean acceleration to a peak velocity, and we have the slowdown, and you'll see that the flow time is marked by these 2 little triangles. Now up here the stroke distance is given because I've asked the machine to display the stroke distance in 11.1 centimetres. So it's very easy to imagine with a patient that 11.1 centimetres is the distance that plug has moved down the aorta with each heartbeat. Stroke volumes up there, and the mean acceleration and peak velocity. These are the variables that I normally have, except I've now changed mean acceleration for cardiac index, just that. But the flow time there is 413, and that's a little bit higher than is said to be normal. But I use flow time in a very secondary way. It's something which I have a glance at, but the key for all my work with the cardio-Q is trying to enable the patient to push up their stroke volume as high as they want it to go. It's all about stroke volume, and the other variables are not quite so important. Now I obviously have to make a confession here, because most of my intensive care is done in the operating room. I'm essentially an anaesthetist rather than an intensivist, and so all of my major surgery patients are treated with cardiac output monitoring, every single one. So how accurate is it? And this was just half the graph that was published, showing the comparisons between the cardio-Q and the pulmonary artery catheter. You see the correlations are all pretty high, and there was at least as many again on the graph with a similar high correlations, which I just didn't think that you really needed to suffer. So I only put half the graph in. So to get some idea of what these other points mean with the shape of the graph, the peak velocity is a marker of contractility, and in a sort of fit 20-year-old you'd be looking at 90 to 100 centimetres per second, but as you get older, obviously this would decrease, and in someone who's 90 you'd expect a normal range to be considerably lower. So if you're in a state where your heart is not beating very well, then you have a low peak velocity and you have a flat dampened trace with a low mean acceleration, so it all sort of gets a bit squashed.
You are hoping this will go on. No, it really doesn't get very well. No, it doesn't. But you would have pointing to you.
I was pointing to me, thank you very much. And so it all gets really flat, and you end up with a little sort of thing like this, which doesn't look very healthy at all. And that would give you some indication that maybe some inotrope therapy would be quite useful at this stage. So the peak velocity is increased by an inotrope, But interestingly, it's also decreased if you increase, it's increased if you decrease the systemic vascular resistance, because of course the heart is then beating against a lesser resistance. So it's easier for it to have a bigger peak velocity, see? It's all so incredibly simple. It's all more simple than this thing here. I keep pointing the wrong way around. So dobutamine will increase the peak velocity, as will phentolamine. But it will be decreased by medicines which obviously reverse the trend there, like esmolol and methoxamine. And hypovolemia, of course, will reduce the peak velocity because there's less blood in the heart. You see? It's really straightforward. So, flow time is really equivalent to the base width of the trace, and it's corrected for heart rate using Bazet's equation, and it's normally about a third of the cardiac cycle. So it's normally about 330 to 360 milliseconds, okay, which is about a third of the cardiac cycle when the heart is beating at 60 beats a minute. So it's inversely proportional to the systemic vascular resistance. So if you notice here that we've got a very narrow trace, you see, very narrow trace. And then the most common reason for this is a raised systemic vascular resistance because patients are hypovolemic. Okay? And it's a better indicator of preload than the occlusion pressure. And it's a very useful indicator of fluid responsiveness because you can give some fluid and you see it widening out. And you can see it before your eyes. And obviously with a low SVR, you get a wide corrected flow time. And the SVR, the flow time, of course, is also altered by some anaesthetic agents that have vasodilation. So this idea of afterload, it affects the width and the amplitude of the wave. So it not only affects the peak velocity, but the corrected flow time. You see, an increase in afterload, and you narrow your trace and you reduce your peak velocity because the heart's working harder, isn't it? It's less easy for it to pump the blood out. And if you decrease the afterload, then you get a big, broad trace with a high peak velocity because it's easy for the heart to pump the blood around, especially if the circulation is full. So, essentially, when I'm in the operating room, I tend to use this device by essentially pushing patients up the Starling curve, and I give them a fluid bolus. It's usually 250 mils of colloid, and I keep pushing them up until I get less than 10% rise in stroke volume. And you notice here that that's where I start most of the time with my patients as soon as we go through to the operating room, with a narrow trace, a nice full broad-based Doppler trace when we've got the patient optimized. And essentially this is the algorithm that I use. It's a very similar one that can be used in the early stages of someone entering an intensive care unit when you're trying to volume optimize them for the first time. You essentially look at your stroke volume or stroke distance, you monitor them, you give a challenge. I give 250 mils because that's half a bag. It's more convenient than changing a bag halfway through a bolus, you see. And then you look for an increase in your stroke volume or stroke distance. You can use either. It doesn't really matter which you use. And if you get an increase, you go back and give another one, just as I showed you with the Starling curve. And if not, you just wait. The only thing that's missing off here is a little thing which says wait 10 minutes. Well, I wait 5 minutes because I'm impatient. But every time you give a fluid bolus, the circulation changes. Every time you give any sort of vasoactive drug, the circulation changes. And you need a little bit of time just to sit back and wait and see what effect your change has made. And it's exactly the same, just with a bit of fluid. You give a bit of fluid, wait 5 minutes, and then assess. And it's all about this, isn't it? If you take an intensive care specialist and you take off 800 mils of blood twice, so 1600 mils of blood, and you're measuring his blood pressure and you're measuring his heart rate, there's not really a great deal of difference in either of those, is there? I would say that most of us in the operating room wouldn't spot that. Who'd spot that in the operating room? Those changes? Yeah, no one, exactly. So what's happening is that he is diverting his blood supply away from his gut. Now you guys all know much more about PHI than me, but essentially, as soon as you start getting hypovolemic, you compensate by dropping your gut perfusion. All right? And it doesn't come back until you retransfuse the blood that he lost initially. Now the line there is at 7.32 because that's the cutoff between elective surgery patients doing well and doing badly. And it's been estimated that up to 60% of major surgery patients in the operating room have their gut perfusion spoiled by poor fluid management. So why is it important? Because gut dysfunction is the most commonest form of morbidity. Much more common than all these others that we worry about. Gut dysfunction is there, and this is a big prospective study of over 400 major surgery patients, and this was done at Duke in North Carolina. And there you go, look at that. The most common. But if you use the stroke volume optimization, of course you're pushing your stroke volume up, which is helping your cardiac index up, your oxygen delivery up, and it all goes up until the demand of the patient, including their gut, is met by the delivery. And then your further fluid bolusing won't increase it because it doesn't need to. And then there's no surprise that whatever part of surgery you apply it to, they go home quicker. They spend less time in hospital. It doesn't matter because the principle is there. You sort out their circulation, they will go home earlier. And this was a study done in Newcastle by Alan Horgan's group, and it shows colorectal patients. The intervention group had the Doppler guided fluids. The control group didn't. And this is what happened to their cardiac indexes during the operation. You get them off to sleep, metabolic rate starts to rise, and so cardiac index of these patients rise. These patients in the intervention group are stroke volume optimized, they have some fluid, and most of the fluid incidentally was given at the beginning here, and their cardiac indexes respond and come up. They continue, and you see this even with laparoscopic surgery. After 2 or 3 hours, when you're really getting bored, you'll find that the cardiac indexes of the patients often rise again. And I assume it's because the metabolic rate of the patients go up again. But you see here that the control group, who did not have that fluid on board, who did not have their stroke volume optimized, have not been able to maintain a cardiac index at the same level as those who had the fluid. So these guys will not be having the gut perfusion, will not be having the splanchnic perfusion that these guys will, because they have not got enough fluid on board to actually get their stroke volume and their circulation up to the right level. And what else have we got here? Right, and that's why Doppler guided fluids is part of most of the enhanced recovery programs in the UK at the moment. Not all, but the vast majority. So in the ITU patient, it gives you a very accurate and relatively non-invasive cardiac output. It's very rapid, it can be used on the ward, and in the emergency room. It's reproducible and it's nurse-led. You can ask your nurses on your ward round, I'd like to know this patient's cardiac output, and 5 minutes later she'll tell you what the cardiac output is. You don't need complicated methods to do it. It's a direct flow measurement from the stroke distance as we described, and you get more feel of the circulation from looking at the peak velocity and the corrected flow time. There's a soft probe for awake patients, and I think that this gives a very important piece of the jigsaw. I think the cardiac output is a very important piece of this big jigsaw that we're talking about, and that's what it does. Nothing more complicated than that. It's very simple. It will just measure you the cardiac output and give you some idea of the circulation from these other variables. That's what it does. So I think we've basically covered what I wanted to cover, and I hope I haven't overrun too much.